Okay. Hi, everybody. Welcome to today's session, Opportunities and Barriers for Genuine Participation of Racialized Communities in CBR, a social determinants of health case study with sub-Saharan African women living with HIV in BC. This is the first webinar in a three-part webinar and discussion series on community-based research with racialized communities, hosted by Community-Based Research Canada. My name is Julia Coburn, and I'm the CBR Canada Program Coordinator and the moderator for today's session. So first, we'd like to respectfully acknowledge that CBR Canada Secretariat is situated on the traditional territory of the Neutral Anishinaabe and Haudenosaunee peoples. In the spirit of reconciliation, CBR Canada is committed to engaging with and learning from diverse Indigenous peoples and communities across Canada, as well as addressing the Truth and Reconciliation Commission's calls to action. So a brief piece about CBR Canada. So Community-Based Research Canada's mission is to advance community-based research excellence in Canada by strengthening partnerships, bridging capacity, mobilizing knowledge, and championing CBR among individuals, communities, and institutions. For 10 years, CBR Canada has honored to have brought together key players of community campus partnerships. So quickly, I want to share where to leave your comments if you have any questions or comments throughout this session. Please leave them in the chat box, which you can find on the lower right-hand side of the screen. So right here. And without further ado, I'd like to introduce today's wonderful speakers. I'm pleased to introduce Ngozi Joe Ikechebelu and Patience Magagula. Ngozi is a PhD candidate in the Social Dimensions of Health program of the School of Public Health and Social Policy and the Faculty of Human and Social Development of Health at the University of Victoria. Ngozi specialized in community medicine and primary health care with a fellowship training from the National Postgraduate Medical College of Nigeria and has over 10 years of clinical consultation work and community experiences with people living with HIV at Chukwuemeka Udumegwu Ojukwu University and Teaching Hospital, which is in Amaku, Aka, Nigeria. A sub-Saharan African woman, wife, and mother from Nigeria, Ngozi works on intersecting socio-structural issues that affect sub-Saharan African women and equity-centered local solutions to climate change with Canadian Coalition for Global Health Research. She currently volunteers her service to the Afro-Canadian Pacific Network of BC, a sub-Saharan African community in Surrey. A board member with AIDS Vancouver Island Health and Community Services, and NCEHR, a community academic research domiciled in Anambra State. I also want to introduce Patience Magagula, the Executive Director of the Afro-Canadian Positive Network of BC. Patience will be hopefully joining Ngozi to help answer your questions during the Q&A period. So Ngozi, I'm going to let you take it away from here.
Yeah, thank you very much. I want to greet everybody that is on this platform. I'm so excited to be part of this. But first, I'll start with the Territorial Acknowledgement to the Lekwungen people on whose traditional territory the university stands, and the Songis, the Esquimalt, and the Sanish people, whose historical relationship with the land continues to this day. I appreciate you all, and I want to also dedicate this to my organization, Afro-Canadian Positive Network of BC, to every woman who lived and died from HIV, to every woman living and is affected with HIV currently. Ahambo Esomdi Ngozi Joe Ikechebelu. Ana m ekene Chibine n'igwe Dumbija n'obodo Canada. And starting on the, so I want to say at this time that we can genuinely heal. When we look at what Kumsa said in 2007, she said that the healing of self is intimately intertwined with the healing of the other. And whatever I do for others, I also do for myself at one and at the same time. So I'm going to use the metaphor of the shoe, using a shoe to explain certain things here, not necessarily meant to be a pun, but using the African and the English proverb. And I also want to say that the African women, when I use sub-Saharan African women living with HIV in Canada, is a unified term. I'm using the African woman as a unified term for it. And this comprises of the female sex and potentially gender diverse women of reproductive age and beyond, heterosexual women, lesbians, queer women, and transgender. One thing we have to know is that the African proverb says, it is the one who lives in the house who knows where the roof leaks. And if you look at the English proverb, it says that she that wears the shoe knows where the pinches are felt most. Everyone loves to wear a shoe. It's a necessary apparel that covers our feet. It's a foot cover, and it protects us from harmful elements such as the cold, such as insect bites, animal bites, and other injuries that might cause infection. The shoe is quite compelling as a metaphor because the shoe as a foot cover is a constant for people, especially for women. In the natural course of life, women shop for shoes. And here, shoe may signify the country, despite the pun. We shop for houses. If we look at it with the African proverb, everybody shops for houses to finally settle in. The varying experiences of tensions and difficulties a woman feels when she's wearing a shoe are like the pinches, the tension in that shoe. And we cannot do away with the role that the shoe play in our life. Nor that of the country where one settles. Like Canada, being a house for every immigrant, being a covering for every immigrant, but there are still pinches. Inside and around the shoes are features. Inside and around the houses are features. So when we look at the shoe, for example, think about the shoe sole, think about the tips, think about the buckles, think about the materials that the shoe are made of. It determines the shoe comfortability and values. And when a woman decides on a country to settle in, there may be occasional pinches. She might not go ahead to exchange the shoes because it's not possible for her, because maybe she has tried different shoes. But she can go to a shoe mender. And when you're talking about the shoe menders, it represents the different levels of the society, other individuals in the society, like her allies, community, organizations, governments, and others. And they collaborate. The woman and the different levels of the society where she went for the pinches she's feeling, they can collaborate using mutually objective and subjective activities and inquiries. And they decide together, this mutual decision, they decide for a better outcome for the challenging pinches she feels. Some shoes may have pinches that are more painful on one side than on the other. And these pains and pinches can be distally, it can be proximal part of the shoe, or even in the midsection. And one thing is obvious as she's wearing this shoe, depending on her context, such as the length of time that she's wearing the shoe. Imagine the length of time she stayed in the country, her recency in terms of immigration, her understanding, the fittings, even the wearer, the woman. One thing is that locating these pinches, which represent holes in the social fabric of the society, needs repair. And for this repair and healing to occur, there must be genuine participation in life activities for this wearer. She knows where these pains are. And when you look at the interconnecting distal, mid, and proximal features of the shoes, it can be analogized to the intersecting determinants of health and well-being of women immigrants. The people who wear the shoe, who can best identify what is working for them and what is not working for them. Leaving the shoe, like I said before, may not be the best option. But one thing she keeps hoping and believing that the shoe pinches might ease off with time when people hear her where she's complaining of the challenges she has. It is the woman that knows it. When you're talking about social determinants of health that are causing these pinches and pains, it could be from her income, it could be from her social status. What level is she in the social status? What is her social status and position in the society? Is she employed? What are the working conditions that she meets in the society where she's working? What is her level of literacy and educational status? What childhood experiences for her did she come with from Africa? What are the physical environments she's experiencing? What level of social support and coping skills? What are the healthy behaviors, and how is she assessing health services? Think also about the culture, the gender, she being a woman, and her race. She's a Black woman, migrated all the way from sub-Saharan Africa. And this woman that we're going to talk about, when we narrow finally to the sub-Saharan African woman living with HIV in BC, she has HIV-related challenges. And we know again that research is showing us that more women from south of Sahara, the African women, that are moving to the global north countries. An example is Canada. Unlike the men, who research has shown that migration for men from sub-Saharan Africa is within the African countries and also Asia. For the woman from Africa, she's heading towards a global north country. Why is she heading there? Look at media globalization. She must have heard about the ideals of Canada as a country. Canada is a country that welcomes immigrants. The belief that she heard from the media about the espoused values of Canada as a country, such as compassion, inclusion, empathy, diversity, and multiculturalism. One thing is obvious, and if we remember the book written by Bristow that was edited by Bristow Peggy, they talked about the Black woman, an example being the African woman. Their roots are getting firmly rooted in Canada, and they cannot be pulled up. We continue to hope in the face of adversity and believe for a better future for our next generation and also for us. And we believe that there is a better future because of social and health justice that can prevail against oppressive violence. And this will come from findings that will be based on a collaborative mutual inquiry, genuine relationships with allies and other disprivileged groups, and that interventions, when there is a collaboration for intervention, when there is a genuine participation, that our interventions, our voices that are heard from our lived experiences can help to ameliorate the tensions that these pinches we feel at a different level of society and help to bring about improvement to improve social and health policy. Now, for my study, this study that I did using keyword searches on the UVic database, University of Victoria, I did a traditional narrative literature review, that is secondary review of research. And I did a critical synthesis and was able to draw certain conclusions within my research questions. And these questions are: what are the key drivers that shape the lived experiences of the sub-Saharan African women living with HIV in Canada? The second one, what opportunities and challenges might researchers face using mixed methods within community-based research? So I used my theoretical framework. I used an intersectional theoretical framework, and also using community-based research within the content of migration, health, and mixed methods. And if we remember that Kimberly Crenshaw was the one that gave the name to intersectionality as a framework, and talking about that intersectionality is not just merely multiplication of the different identity categories that the woman of color carry, but we should go beyond that, looking at how we can analyze how particular identities and socioeconomic conditions that she go through affect or bring about processes of oppression or privilege, and how this can impact on policies and the different institutions that she passed through within structures of power. Now, what am I saying in essence? The experience of the African women in Canada is quite different from the white women in Canada, or the African women with HIV in Canada and other women with HIV/AIDS with HIV in Canada. We must understand the relationship. There is a relationship between these identities that can generate privileges and oppressions for some while marginalizing others. I looked at community-based research, their definition by different groups, and I liked the one by CIHR, and it brought out certain elements that resonate with me. It brought out collaboration, it brought out social justice, and it brought out capacity bridging. If you look at the definition, it talks about is an opportunity for community members to work alongside the academy as interested and equal partners with distinct assets coming from all stakeholders to respond to an agreed upon community challenge or challenges that can strengthen existing capacity using established activities of phased inquiry to improve and sustain societal equity and knowledge. I was also able to look at CBR principles. We know about leading scholars and their role. Israel et al. 2013 talked about 9 principles. Wallerstein and Doran talked about they adhered to 8 principles for CBR. I liked the one by Minkler et al. They added 2 that look at the challenges of disprivileged groups like mine. It talked about an open acknowledgement of markers of social position like race, ethnicity, social class, and it was able to concretize cultural humility. I like that. And also a guarantee that CBR research will involve scientific enterprises that will bring about rigor, reach, and relevance. Thinking about the reach, relevance, is it relevant? And we all know that in community-based research, the community members are the key. They are the key. The power is equalized. The power hierarchy that we see in traditional academic research is not there. And when you look at the CB principles, 4, I take 4 to be core, and that is identifying the study community, equitable participation of stakeholders, mutual engagement of community academic researchers and other stakeholders, and look at also community translation, knowledge translation and exchange. For my study, still talking on this study, I looked at 5 studies that, and they were community-based mixed method research. The 5 of them were Logie et al. Logie et al. 2012, they studied ethical challenges and opportunities in working with community peer research assistants. Why Etowa et al.? This was in Ontario, Canada. Etowa et al. Is in Nova Scotia, and they looked at the Black women of African descent. We also know about I looked at the Black study by Dobonso et al. 2012, and the first study on African health, the East African health study in Toronto, the East study by Gray et al. And currently there is a new group that is also looking at sub-Saharan African immigrants. One thing resonates across these 5 studies. They used community-based mixed method research, whereby they started with the qualitative aspect of the study. Before they use their they now use the findings from the qualitative to move on to the quantitative. So that is one thing. We are able to see the benefits of using the mixed method research. Other studies used them. There were other studies that used either the qualitative that I also looked at. Another thing was common one thing was basic. These 5 studies looked mainly at people of the African and Caribbean and Black communities that are in the east and the central part of Canada, except for the one by De La Cruz, the New Heights study that is looking at African immigrants from the western part of Canada. Another group is coming together, and we'll talk about this group. Yeah. Now, if we want to we're looking at now the sub-Saharan, we're narrowing down to the sub-Saharan African women living with HIV in Canada. One thing is obvious. We know that globally more women are affected by HIV, and most these women are 2 out of 3 women in sub-Saharan Africa. We have 6,000 daily new infections globally, and 2 out of 3 of these women are in sub-Saharan Africa. And the majority are young women who are between 15 to 24 years. They are the ones that are affected disproportionately. Like I said earlier, more women are moving to global north nations. And when we looked at, I saw something in Statistics Canada. Before 1998, the source of Black immigration was from the Caribbeans. But now the source of Black immigration to Canada has changed between 2011 to 2015. And most of these migrants are coming from 5 major countries. And they are Nigeria, Haiti, Cameroon, Cote d'Ivoire, and Jamaica. So you can see that you have more from sub-Saharan Africa. And when you look at, I looked at the current HIV surveillance report of 2018. Despite the limitations we know about using a surveillance report, but one thing is obvious, it tells us why we need to disaggregate. If we're just talking about Blacks, we are thinking about HIV prevention approaches and how we can reframe HIV prevention approaches for this group of women, this group of people coming from Africa, who are now the major source of Black immigration. For sub-Saharan Africa, we have about 41 of the countries are out of the 72 countries recognized, known in Canada, reported in Public Health Agency of Canada. It talked about 72 countries that are in the HIV endemic countries. And majority, 42 sub-Saharan African countries are included. So we are in the majority, and we just make up 2.5% of the Canadian population. This is a surveillance report, remember that. I also want to talk about prevention of maternal to child transmission. You see that most of it, 259 infants were perinatally exposed to HIV in Canada. And of these 5 infants that were confirmed to be infected with HIV, 5 infants were confirmed to be infected with HIV, and 54% of the perinatally exposed infants were born to mothers identified as Black. And the maternal region of birth of these infants was Africa. Now I'm coming down to looking at sub-Saharan African women who are living with HIV/AIDS in BC. What I was able to find out, we are talking about what are the opportunities, what are the barriers for their genuine participation. We look at it, remember that we're talking about the Black race, good, African, Caribbean, Black. But one thing is obvious, for the different groups, think about their context. They have different contexts. If we look at the history again, look at the historical input of Blacks in Canada since for over 400 years ago. But history shows us that the African community started coming in like from the 70s, despite the African descendants that migrated 400 years ago from slavery, then also the Underground Railway Station. So when we look at, there is need for us to disaggregate. because we are talking about the HIV cascade of care and how we can particularly be specific to this group that constitutes the present source of Black immigration to Canada. At the individual level in BC, one thing I was able to find out, I was thinking before that for everybody that, for the people, women with HIV in Canada, they had it in Africa. But one thing I was able to find out, it was a blind spot for me. One thing I was able to find out was that some got it while on the migrant passage. Another thing for the individuals is there's this disinterest with research. Remember that in traditional academic research, you see researchers working not just relating with the community. No, is that power is they just come in and get the data they need and move up again, just like the helicopter syndrome. You land, get all the information you need, and you zoom off. You don't care about the community. When you're talking to this individual, they tell you, no, they just want to use us as experiments and find information and move out. And this could also be related to the HIV-related stigma and discrimination they feel. We're going to see from the study, we have a case study here, and we're going to talk about the HIV-related stigma and also the intersectional stigma, the intersectional identities of these women, and also the intersecting social determinants of health, how it impacts on their health and well-being. At the community level, we're going to see my community, ACPNet of BC, and we are going to, there's a slide that we're going to see certain things about my community. But at that community, the structural barriers we are going through now is structural racism. There's this systemic inequalities at the healthcare institutions, at the immigration services. First of all, as a community, we know that the community-based organization is a meso group. It's acting as a bridge in between, as a bridge to relate with even the individuals in that community, in an identified community, and the higher group like institution, the government, and provincial level. Yeah, so the CBO is in between, is a bridge. But what are we experiencing? For our community work, we are lacking funding. We were together, myself, the executive director, and myself, and other members in our community. We had a meeting, an online meeting with CAF and HRF. And I remember that I said, it's just like starvation in the midst of plenty. When you are in a pool of water, around water, but you're still washing your hands with saliva. We lack funding for the community work we're doing with this, with the sub-Saharan African women and the people living with HIV who migrated from Africa. We are not being funded. Our executive director, Patient, has been in this work with other committed members since 2009. When she comes in, maybe during the questions and answers, she's able to come in today. We're going to hear, she's going to tell us so many things. If not because of her compassion, when you hear her story, when you hear her talk, you'll be wondering, how are you able to do the work? How are the other members, also the men in this group, how are you people able to do the work without funding? And you see her values, compassion. She will tell you, I can't leave it. If I'm not there, who will do it? If somebody decides to sponsor me for private health care, how about the other women? There are people, they don't have the social support, or maybe they don't have the links for somebody to help them in private health care, even in immigration. So, and another structural challenge for those of us in BC, you see that staff attrition. Most women coming in, most people coming into the organization, they just come in for a brief time and they move. You can't blame them. because as migrants they have to suffer, they have to survive. They came with their family, their children. They have to feed them, they have to send them to school, they have to provide for them for transportation, other social determinants of health, for their housing. If we use somebody that is on disability, that person might earn about $1,100 by the time she pays for her rent, which is about $700. How will she survive with $400? Do the mathematics. You understand what I'm talking about. I've talked about challenges of access to institutional socioeconomic products. And that is why we also need culturally trained, culturally safe peer navigators. We are going to talk about that in the non-structural barriers. Now, look at this case study. There are two health facilities. I'm using Greater Vancouver as an example. I call the two health facilities A and B, that are about 60 kilometers apart. For somebody that does not understand it, my community, there is an area where they congregate more. The nearest health facility, if someone decides to take a transport, like a cab, she pays about $15. But they will not go to that facility. They'll prefer to go to the facility that is so far, where the pay for transportation is about $95. The other one is about $85. But they prefer to go there because of HIV-related stigma, the experience of our individual members when they've gone to the closer health facilities is nothing to write home about. One person went there and she hadn't traveled, she hadn't left Canada for a while. And she said that when they came, when the health workers came to talk to her and everything, they were clothed. They asked her about Ebola, but she had not traveled. So the majority of our members would prefer to go close to, they live close to A, but they'll prefer to go to B despite the time. Think about the direct and indirect cost that is going to impact on them. Letters have been written to the health facilities, but nothing have been done. What is now the implication to community leadership? And that is why we need allies. We have allies in this community that are helping us, but we need more allies. We need more collaborators. We need more advocates that can come to help us in this fight, especially when we are talking about prevention, HIV prevention approaches. The need for culturally led peer navigators. Where we are coming from in Africa, maybe because we grew up there, and there is a different way in Africa we access healthcare, because it's easier for us. But here, because of language barrier, because of communication barrier, most of our community members, the language that is common to them is Swahili and Arabic. You see why we need a culturally led peer navigator that will help. When somebody is sick at home, she can call. If it's the child that is sick, they can call the peer navigators. Other groups in BC, they have culturally led peer navigators. Why do we not have ours? Our executive director has made a case. There was even one time they brought somebody from another community, from another group, from another race to come and meet her, to teach her how to be the peer navigator for people living with HIV from Africa. Let's ask ourselves that question. Now, we're also looking at cross-cultural challenges. Yes, we understand that we have our culture, also the culture of the people, but this is where education and empowerment program need to come in to help us, to help our community, so that we can understand about the culture of the society, that is hosting us, that has accepted us even in their community. Cross-cultural challenges, how we can overcome this is when we have empowerment program. So the institutions, immigration services, so many people will tell you when you need to fill the form, despite you're in Canada, it's not so many questions that you don't even understand it. Trying to access healthcare, going into the hospitals is like a maze. So much signs post, so much you can't even enter into the hospital if you don't have an appointment, except it's emergency. Somebody was telling me yesterday, one of our members was telling me that she's been sick. She's been complaining of this pain for over 6 months, and she's been given pain relieving drugs. For her to find out, she's been telling them, send me for, I think I should do further investigations. And she had to go to another doctor. Why? Because she knows her rights. She understands her rights. She's been empowered. She's had this transformational agency due to the different programs she's been to, and so she knows her rights. And she went for an ultrasound for her to find out that she had kidney stones. For over 6 months, she's been going through the pain. Those of us that are in the healthcare, we know the pains that are associated with kidney stones. Now, the non-structural barrier. I want to say that prior to COVID, it was a challenge accessing food for our community. But with the COVID, so much grants coming in, so much gift cards and everything, and our community, we are doing everything possible to relate with our community members, trying to reach those that are far in Vancouver Island so that they can get their food card, delivering foods for them. Despite the physical distancing and social distancing, we are well equipped using our gels so that we can prevent ourselves, equipping ourselves. But the most important thing is that we're getting food to the people, to our people, to our community. We are getting the gift cards that they need, even for their feeding. And using this community-based research, we were thinking that they needed more of gift cards for African market. But with time, we found out that there needs to be diversity, not just gift cards for African markets, also to go to like Walmart and other grocery shop. Another thing is social exclusion. Because of that stigma, Chambers et al. 2015 talked about the third phase of the HIV epidemic, and this is stigma. How can we fight the stigma at the level of the healthcare workers, apart from even the internalized ones, the ones from outside?
Ngozi, sorry to bother you. I wonder if you could try putting your headset on. Your audio is cutting out a little bit.
Okay.
Thanks, Ngozi.
Yeah, you hear
me? No, I can't hear you at all. Sorry.
My headphones. Yeah. Thank you.
Actually, yeah.
Okay. Talking still on the social exclusion. Because of this stigma, they find it hard even to relate with other people, both those from their community and outside, because they're scared that they might get their children will be taunted at, their children will be made fun of. I know somebody, she was saying, she said something, she said, I told my kids I'll tell them something when they're 18 years old. They have a time for our community. We have a time. We decide, okay, this is the time we want to talk to our children about this, about the HIV. Yeah. Another thing is mental health challenges from fear of deportation. We've had experience. We lost one of our community members. She was deported back. When we're talking about representation at immigration centers, there is need for culturally led navigators, representatives that can represent our community. We know where we're coming from, the context where we came from. Most of the African countries, political challenges, environmental challenges, social issues. We know, we understand the language, even things that are said and unsaid, even unvoiced ones, and even the voiced ones that are not so overt. we understand because of the context of where we're coming from. So they decide to stay indoors, they are hidden, they don't come out because they're scared. Somebody was talking about HIV criminalization, and she said her understanding of HIV criminalization was that she thought that if you're positive, it shows you are a HIV criminal. And that was her understanding. Till she was empowered, she was educated about it. Now, even for our next generation, we have to keep talking. We have come here, the sub-Saharan African women moving to Canada are rooted here. Yeah. Then risk behavior, my time. So now look at opportunities. One opportunities that is obvious is that for our community, we love this community-based research because of that power hierarchy is not there. The academy, when you have this genuine involvement with the academy that have these values that are humane, cultural humility, compassion, when you work with the academy, the community that works with the academy are able to have that relational process. One of my professors said, is not just doing research. When we're doing research, we should do research from the heart. And when you're doing it from the heart, you're talking about values. So research processes I've talked about either qualitative or quantitative, community-based research, or community-based mixed method research approaches. In relational processes, it helps in the leadership and the governance, such as in CBR, you see community academic partnership. There is this, our community is coming together with University of Victoria in the Faculty of Human and Social Development. We are coming together for a partnership. In CBR, you see that our capacity of the members are built, new members, whatever level that we are coming in with the level of our capacity, CBR helps that building, strengthening of our capacity and bridging. Most importantly, capacity bridging. There is something that we Africans, we know. There is something based on our culture. Wilson talked about culture as an intervention. We have that cultural knowledge. Genuine mobilization, community mobilization can help to bring about knowledge production because we talk about our culture. We use formal and informal strategies that we can use culture to bring out our people wherever they are, whether they are hard to reach or not hard to reach, because we know them. Even with these opportunities, there are still challenges. The challenges, cultural challenges, ethical, methodological, and practical. But I want to talk about drawing on the research strengths. If we can draw on the CB, community-based mixed method research strength to mitigate the challenges. A typical example is the relational strength. In relational strength, when you look at the ethical issues, not just about looking at the ethical issues, thinking about confidentiality, privacy, accountability, because the researchers are not just aiming to get data for their promotion, they know that it's all about building agency of the other. So that relational strength is important because if relational strength is not worked on, the challenges can bring about conflict. And we know that so many community-based groups or so many organizations have broken down due to lack of inability to manage the conflict that came out from poor relational approaches. Community buy-in. I keep on talking about community buy-in, and that is what how we can effectively mobilize any community, this privileged community, and like mine. Community buy-in, who is on the table? That you got somebody from Africa or you got somebody that is Black is not enough. Which community that you're trying to work with? Remember that if you're talking about Africans, working with Africans, you have to get the community. Community buy-in, who is on the research table? Who is on your research table? And who is not on your research table? The person that is not on your research table is very important because you have lost that voice. But when there is a genuine, effective mobilization, we hear the voices of everybody and their challenges. Another thing is community buy-in. Where do the Africans congregate? At their religious center. Think about churches, think about mosques. They congregate more, they come more there. We can also look at opportunities of community-based mixed method researches being done with faith-based organizations, despite the challenges that research has shown that comes with faith-based organizations. But this is something that can be overcome with the leadership in community-based mixed method research. Another thing is the methodological strength. When we are talking about questions, we have to use peer researchers that are from the community, because they understand this question. Can we frame it like this? It might not be understood. This data that we got, this is how we can interpret it, this is how we can analyze it, not removing what the community participant has said. And another one, lastly, is community appreciation and safety. We can never talk less of this cultural humility. So many organizations understand the need for culture. When we come together, we like to sing. When we come together, imagine during a focus-based discussion whereby the community with the researchers, they're cooking in the kitchen. And from there, you encourage, there is this peaceful and calm atmosphere whereby issues can be can be brought up, and you can discuss your questions. Now, ACPNet. If you go to our website, Afro-Canadian Positive Network of BC, if you go to our website, www.acpnet.org, just Google ACPNet, you will see it. We are a support organization that was founded by people living with HIV from African descent, not just people living with HIV, people that are affected by HIV in BC. People think it's only for those that are positive. No, ACPNet is not just for those that are HIV positive, those that are affected. Any African, you are a migrant from Africa, or from any other place, you can be a member. You can be part of us. It was 5 people came together, and one of them is our executive director. She's been there since 2009. We're a charity group. We are recognized in Canada. One thing is obvious about our group: we care so much about people who are living with HIV and who are affected by HIV. Within our mission, that using peer support, using positive values, we can get to our people. Then we're based on social justice. What is fair? What is right? What is true within culture? I'm almost to the last, getting to the last. Now, this is the latest community academic partnership team, and a combination of a community-based organization in BC and University of Victoria Faculty of Human and Social Development. This is Charlotte, this is Catherine, this is Nathan, this is Muchina, and this is my director, Patience, and this is Devi, and this is Ngozi. This is the latest community academic partnership that has come together in BC to work with the African community. Limitations, next step, and gap. For us, it's a totally social context, especially in terms of research, because what endeared me to community-based research when I came for my PhD study, and I heard the word community-based research, I thought it was just working in the community. No, it's more than that. But in Africa, if you Google it, there are not so many community-based research in Africa. You see it in South Africa, there is one in Ghana, but none from Nigeria, where I came from, that are just about to spring up. But in Global North, we found positive community outcomes and individual health outcomes from community-based research. So for us, it's a different social context when we have to empower and tell our other African members and friends that this is not just a power thing where the researchers want data. No, it's more than that. They want to hear you from the beginning of the study to the end of the study. It's all about the community. Public health implications. Remember, Canada is aiming for the UNAIDS approach of the 1990 strategy. And if we're talking about meeting this agenda, we have to think about the HIV prevention approaches that is more than the biomedical intervention, to look at the social issues and reframing HIV prevention approaches. Prior to one gap that I noticed in my study, the need for home meetings, but that came with COVID. But even with COVID, we know that just like we are delivering our health, our cards and food to our community members, we can still do the research. We need, this is another gap. We need researchers, we need allies, we need advocates for our community, and that is in the form of institutional navigators, culturally led and safe peer navigators that understand the culture, that are part of us, that will now be able to advocate for us. Yeah, in conclusion, I was able to find out from my study, and this was my conclusion, that based on analysis of community-based mixed method research with ACV population, I was able to reach this following conclusion: that CBMMR can take into account the intersecting social factors that affect the Black African women migrants more effectively than other research methodologies. It can effectively use social and cultural means to engage, explore, and comprehend daily experiential challenges of these privileged individuals and communities in the short term. In the medium term, it can develop, cultivate, strengthen, and sustain the leadership, community academic alliance, capacity initiative. While in the long term, just as we saw from Gary's study, the East study, is able to generate, develop, coordinate, and effect mutual interventional strategies from the research findings for multi-level health and health equity outcomes, such as HIV prevention approaches in the long term. Despite the research constraints, genuine academic partnership can engage the complex intersecting socio-economic and historical realities, oppression, marginalization of the sub-Saharan African women's experience with HIV through migration and displacement. And the latest CAP partnership between ACPNet and UVIC, Human and Social Development, are also doing this, especially in the Western Canadian BC concept. Thank you. Dalono Ekenemunu.
Thank you. There's my mic. Thank you so much, Ngozi. That was such a wonderful presentation. You've imparted an incredible amount of knowledge onto us, and we just so appreciate it. I could see lots of feedback here in the comments and chat bar. I just wanted to remind everybody that this webinar has been recorded, and you can find the webinar recording on the website. The link is below. So we just have a couple minutes here for questions. I saw earlier there was a really excellent question, some big questions that came up from Betty. So maybe I'll ask the first one you've listed here. How do we move research from someone coming in and taking knowledge out to a relationship of reciprocity?
Yeah, okay. Thank you for that question about reciprocity. One thing about reciprocity is you see that in traditional academic research, it's not something that is there. But in community-based mixed method research, the academy are able to reciprocate in various ways, being allies, being collaborators, even even for the people that are from the community, reciprocating, being there for them, working with them, working with my community. Anybody that wants to reciprocate, when you come in to be part of us, either in ACPNet of BC or even researcher, the picture I showed there, there are more of the researchers in that latest team from UVic. There is somebody else that is not in that picture. Reciprocity, being there for them, giving back to the community, all that you have, the knowledge that you have, because we are talking about knowledge production in community-based method research. So reciprocity is part of the principles of CBR, and that is something that is a principle that has to be maintained even for the community, and not just for the community, because we are talking about the scientific enterprise, relevance, reach, rigor. This can be reciprocated. This can be done. This research, like what we find out, or the research we hope to do, it can be reciprocated. It can be done in another community, with another disprivileged group. So reciprocity is an important part of CBR principle and must be maintained. When I talked about the CBR principles that resonated with me, I forgot to mention that in as much as I named 4, there are about 9 of them when you're looking at Israel et al. The other 5 can still be imputed into that first 4, or into the 4 that I talked about. And one thing is obvious: who is on your table? And that is part of also reciprocity. Who is on your table? Genuine representation of the members, and what are genuine representation of the challenges of the community. Thank you.
Thank you, Ngozi. And I think you just really spoke to the nuances of just who's on your team, and you really helped walk through the differences in the culture. You know, you don't just have a Black person. You have to understand there's so many different cultures, and just it's a time to really have a deep understanding of that. And there's so much knowledge already in our communities. I have a question here from Rich, which was, do you have researchers and champions on the mainland? And this is coming from Fraser Health Authority.
Say again?
Do you have researchers and champions on the mainland of BC?
Yeah, that is also what I was able to bring out. When you're talking about researchers, we have community researchers, we have academic researchers who are of African origin and who are working with in our community. So they are there. Remember what I said, using culture as an intervention. It's not just when you're talking about researchers, capacity bridging. There is something the African researcher, the African community worker knows and can bring out for knowledge production. So thank you, Fraser Health, for this question. And we have the researchers in our community.
Thank you so much, Ngozi. And I guess just in terms of time, we have 1 minute. I wanted just to share a couple of things. So first and foremost, please join us again. Well, Ngozi is going to pose a couple of big questions from this webinar for all of you to start discussing with each other. And we'll try to find ways that you can actually take all of the information and knowledge that Ngozi's imparted on us and these ideas, and see how that can actually play a part in your own work or organization. And we also have some other wonderful events and webinars and discussions in this community-based research with racialized communities series, one in October with Dan Wilson, and another in November with Dr. Rhonda Hackett, which is looking at decolonizing research systems. So we want to see all of your faces there as well. And please consider becoming a member. As of next month, we're going to open up our live discussions. As we're a nonprofit for members, So please consider looking at the institution list. If you're in one of those institutions, then you will be considered a member. If not, there's individual member options. But I just wanted to also mention that we so value community participation in this network. It's not only that something we value, it's needed. So there are free membership options. If you're a community mobilizer, please register. And yeah, and so thank you again, everybody. Take a minute to share your feedback and enjoy the rest of your day. Thank you again, Ngozi, for just such a wonderful presentation.